Hi, welcome to Cardiac MRI Simplified at www.mricardiac.com. And today I have the privilege of doing the 200th case. It's titled Mitral Valve and Annular Terminologies. It's one case a week. Priya Chudgar, my colleague, does 3 weeks in a month. I do one a month. So this is my 45th case. And we've been doing this now for 3 years and about 9 months. We started in September 21. And I guess we're just going to keep going. So, big shout out to Priya for being the driving force behind this site. And like I said, it's my privilege to be doing this. And today I'm just going to focus on the various mitral valve anatomy and pathology terminologies. And so this is a 59-year-old, the MI is not relevant, but the idea was to talk about all of these entities here. You can see some prolapse and some billowing, and there's a hockey stick appearance. So what are all these terminologies? Two papers published recently have made it easier to understand. The one is predominantly related to MAD, but was published earlier this year in JMRI, and the other was in radiographics as a pictorial essay a little late last year, and this is from Prabhakar Rajaya's group. And we're just going to quickly run through some of these definitions. So, stenosis and regurgitation are easy. This is a patient with rheumatic heart disease, and you can clearly see the mitral stenosis and the mitral regurgitation very well here. Thickening, and while it's not specifically mentioned where you have to measure, I guess anywhere would be fine. And measuring and any thickness greater than 5 millimeters is considered significant. The hockey stick and fish mouth appearances I did discuss in detail twice. One was in a post in my Case of the Day series on YouTube, or on YouTube, and then the other was a case at mricardiac.com. So this one is the one from Case of the Day where you can see the MS and MR, and if you look at the static images, there's this classic hockey stick appearance with calcification. There's a fish mouth in the short axis static image here. And the three chamber shows everything. It shows the MS, the MR, the AS, and the AR. So this patient had involvement of the aortic valve and the mitral valve. And that was the case that I'd put up at mricardiac.com, which actually sparked this entire post on mitral valve disease, because I started with rheumatic heart disease and I said, let's just tease out everything else. So then what about prolapse, billowing, and flail? And if you see that same patient I started with, you can see that the anterior mitral valve leaflet is kind of prolapsing into the left atrium. But is that really prolapse? Now, billowing is when the leaflet is more than 2 millimeters into the left atrium. And this commonly is defined as prolapse 2. But if you want to split hairs and be technical about it, then it is when the coaptation point is seen within the left atrium by more than 2 millimeters that we actually use the term prolapse. And I spoke to a couple of cardiologists who do echo principally, and they too said that sometimes they'll just use billowing instead of prolapse, and sometimes they'll actually stick to the technical definition of prolapse. But I think it's important that we understand that there are different definitions. So the coaptation point in the left atrium compared to the annulus by more than 2 millimeters is prolapse, whereas only the leaflet in the left atrium more than 2 millimeters is billowing. Now, prolapse and billowing should be looked at on 2 and 3 chamber views rather than 4 chamber, as this case shows. Here we can clearly see the prolapse, but on the 4 chamber you don't really see it very well. Then what about flail leaflets? And Priya lent me this case because I couldn't find one. And here you can see the posterior mitral valve leaflet. It actually curves in into the left atrium, and that is what a Flail leaflet would look like. And I think it's beautifully seen on this 3-chamber view where the leaflet just goes in and then curls in into the left atrium. The static images don't really show that as well as the cine images. So that's prolapse, billowing, flail. Easy to diagnose and pretty much easy to understand. One small thing though, that the billowing can affect individual scallops. So here you can see this patient where there's clear billowing with some calcification of the mitral valve leaflet here, but not this scallop here. And so what does that mean? Now, if you were to look at this in terms of the short axis cross section, this is actually billowing of the A3, which is the anterior scallop or the A3 scallop, whereas the A2 scallop here doesn't show billowing. And I'll just run through that cine once again so that you get that sense here. And so each scallop can behave differently. So what are scallops? And this particular article headed by Pankaj Garg has this beautiful diagram showing us the A1, A2, A3 and P1, P2, P3 scallops. And this is just a placeholder here of the anatomy of the mitral leaflets. This is more for me than you, so I'm not going to read this out, but whenever I'm stuck with a case, I sometimes go back and refer to my own posts that I've done at mricardiac.com. And the same thing with the Carpentier classification. It's not really relevant to today's lecture, but it's something that I've put here in case you're interested. But you'll find this in most of the references that talk about mitral valve disease. And even the radiographics article has this beautiful diagram showing us the A1, A2, A3 and P1, P2, P3 scallops. And at present, there doesn't seem to be any relevance to reporting findings on a per scallop basis. And then lastly, we come to MAD, annulus expansion and curling. And if you look at this 45-year-old with MR, I mean, clearly there's billowing, there's prolapse, there's regurgitation, but there's something else happening along the inferior and anterior walls where there is disjunction between the annulus and the myocardium, and it's almost 10.4 millimeters here in end systole. You can see that here. Normally, the myocardium is flush with the annulus, and you're not seeing that here, and that's called mitral-annular disjunction, and it is supposed to be associated in some instances with ventricular tachycardias and rarely sudden cardiac death events. And you can see the difference, right? That's a normal patient where the myocardium is flush with the annulus, and here you see this disjunction. The disjunction also leads to abnormal or wonky behavior of the annulus, which can lead to abnormal annulus expansion and end systole. So normally the annulus should contract in systole and expand in diastole, whereas with MAD that is reasonably severe, there is expansion in end systole and contraction in diastole, which is the opposite behavior, whereas in a normal patient you will see contraction in end systole and expansion in end diastole. So that maybe is a marker of the severity of the MAD. And the other thing that happens is curling. If you look at this in more in diastole here, you see that the annulus suddenly jerks away from the myocardium into the left atrium or in the opposite direction. So it's like as if it's curling away along the posterior aspect, and that's called curling. Again, you could try and look at it on a static image, but it's best appreciated only in the cine images. Somebody did try to quantify it, but I don't think anybody else has tried to measure curling. So at present, if the MAD is greater than 6 millimeters and if there is systolic expansion and curling, then that is considered to be perhaps anatomically significant MAD. And you can see this patient here where there is mitral annular disjunction, and you can see here that there's a sudden upward jerk of the posterior annulus compared to the myocardium here, which is what curling means. So that was the aim today, to just run through all the terminologies which would basically help us when we're reporting cases where the mitral valve is the focus. These days we do get patients with mitral regurgitation where we need to tease out the anatomy. And though echo pretty much does everything very well, if the patient comes to us, I think it's understood that we also need to make sure that we report everything correctly. Also, MAD is better seen on MR than on echo. Now, some of these things will become more important in the years to come, some not. And will fall by the wayside, but we'll only know when that actually happens. That's my WhatsApp channel. That's the book that started it all, my Atma's first book. And thank you so much for being part of this journey of ours and for viewing this.